Good afternoon, everyone, and good morning to those who are joining us from the West Coast. Thank you for attending today's webinar, Planning for Post-COVID-19 Practice Startup, presented by Brian Ramos, the Chief Operating Officer of Capital Anesthesia Partners. Brian is also the President and Chairman of the Board of Directors for Maryland MGMA. Please be aware that there will be a question and answer portion at the end of today's webinar. They may be submitted in the question box located on the right of your screen, and they will be answered in the order received. Additionally, the presentation slides can be found in the Handouts section, also on the right of your screen, and they will also be emailed to all participants following the completion of today's webinar, as well as a recorded version will be available on our COVID-19 resource page. Again, we would like to thank you all for attending, and I will now turn things over to Brian.
Thank you, Bria, and good morning. Thank you for allowing me to speak with you for the next hour. We have an incredibly large audience today, all the way from York, Maine to Bellingham, Washington. And I don't need to tell you that we're living in unprecedented times. A lot of the webinars that I've attended in the last few weeks have focused on the immediate impact of the coronavirus to the medical industry. They focus on human resources methods to reduce salary expenses through furloughs and layoffs, how to apply for federal stimulus funds, how to care for patients for urgent or emergent care. And while these sessions have been very helpful, they've focused on the immediate issues. And while this is critical, I think it's important to start looking at what the future will bring for our industry and specifically for your practice. But first, a little bit of background to set the stage for what we're going to discuss today. As of yesterday, there were nearly 600,000 cases of coronavirus in the United States and its territories, hitting every single location around the country. And sadly, we've lost over 23,000 Americans, including my cousin Dan Spano. The rate of infection for coronavirus is significantly greater than we originally anticipated, and the not factor, the R naught factor, effectively how easily a person can transmit the virus, is essentially for every one person, they transmit that virus to 5.7 people. And so what that means is that everything is shut down, as you know, everywhere in our country. So this is a photo of Pike Place Market in downtown Seattle on a typical day, packed with tourists, versus what it looks like right now. And no sector of the U.S. economy has been spared, with healthcare, as you know, having been significantly impacted. According to a recent MGMA stat poll, 97% of healthcare leaders reported a drop in patient volume, with 71% of those practices experiencing a reduction of 50% or more. All elective surgeries and procedures have been canceled. Most medical offices have closed, and we're limited to urgent or emergent and pandemic-related services only. And we've been forced to rely on telehealth to care for patients who really need care urgently, but for whom we can't see in the office. And the American Academy of Family Physicians has issued a rather bleak forecast where as many as 1,840 counties across the country could face a significant shortage in primary care as soon as June because of medical office closures and cutbacks due to coronavirus. Worse, the figure doesn't include reductions at hospitals and specialty clinics that will also feel the pinch. And access to healthcare will be limited, particularly for those in our rural communities. And so we're busier than ever. And while we've always been busy, it's really, really busy and new. We're in a constant phase of learning. We're overwhelmed, and it's hard. So what are we dealing with? Well, telehealth first. Many practices were really unprepared or underprepared to move to telehealth immediately. And so, most practices have either had to ramp up that service or find creative ways of providing telehealth services because they weren't adequately set up before, including the use of FaceTime or software like DoxyMe. We're sourcing and allocating personal protective equipment at records pace. We've laid off or furloughed staff. We've conducted financial analysis to understand the impact of volume reductions or closures. We're trying to understand new coding and billing requirements, while at the same time keeping abreast of all the regulatory changes that the federal government has implemented in order to try to make our lives easier. Some of these are temporary, some may become permanent. We've applied for federal stimulus funds, such as the SBA 7A Paycheck Protection Program loan, and we're still trying to figure out whether we can keep and use the HHS stimulus funds that appeared in our bank account last Friday. These are just some of the issues we're dealing with at work, never mind other issues at home and in our communities. And while we're very busy, it's hard to stop and step back so that you don't miss seeing the forest for the trees. We have to avoid becoming so overwhelmed by detail or the current issues. And to that end, it's important to begin considering how to plan to restart your practice when the pandemic is over. So I don't have a crystal ball and I don't have all the answers, but I'd like us to begin thinking about and considering some questions and issues so that we're prepared to reopen our practice. So what does over look like? And when do we return to normal life? Well, I don't know. In fact, nobody knows. So we're all, unfortunately, in good company and also uncharted territory. But there are some people who have started giving this serious thought. Dr. Anthony Fauci of the NIH says that we're not going back to normal without a vaccine or treatment. And in other interviews, he estimates that a vaccine is likely 12 to 18 months away at minimum. To provide more specificity on the topic, Dr. Scott Gottlieb, a former FDA commissioner in the Trump administration, and his team at the American Enterprise Institute developed an easy-to-read report on the 4 major stages of response to the coronavirus pandemic. The report provides details about the current stage we're in, stage 1, slowing the spread, as well as how to reopen by region, cautiously, until stage 3, when we have developed a vaccine. The plan is fairly consistent with many of the other plans circulating, including the Center for American Progress Plan, the Harvard Safra Center Plan, and the Paul Romer's Plan. So some of the recommendations from the AEI report include the following: reopen slowly by state or region, continue physical distancing, maintaining sterilization and cleaning techniques, wearing masks in public for the foreseeable future, limiting activity out of the home for those people who are at risk of contracting and having serious reactions to coronavirus. And then finally, needing to develop increased testing capabilities, both in order to screen the patients that need to be screened, but also have some surveillance mechanism so that we know the true impact of the virus in the broader community. So, given the timeline for the development of vaccine, a minimum of 12 to 18 months, and the anticipated recommendations that I just reviewed, how do medical practices prepare today to function in stage 2 for an extended period of time? Let's look at some ideas for consideration by functional area, namely financial management, human resources, and operations. You can use these slides to develop checklists or divide responsibility among members of your management team. The ideas here are in no way exhaustive. In fact, I'm certain that I haven't thought of many issues directly related to your practice or mine, but they should be able to serve as a starting point for discussion and review. On the financial management side, here are some initial thoughts for you to consider. Startup capital required. So cash collections have obviously grinded to a halt. If your volume has been reduced by 50% or more, the days in outstanding AR have dropped, and so you've collected most of the cash that you should have received by now for all cases before the pandemic. It's going to take several weeks from when you restart for those new claims to be paid. Hopefully based on your historical DSO, although the payers are having the same issues that we are in terms of both operating cash and personnel. And so there may be further delays. So taking your old DSO and applying that may not be actually accurate. You may need to add a little bit more time. And you need to consider your practice a startup because in effect, you are or you will be. There are deferments that our practices have taken as a result of the slowdown in cash that have payback terms. And so we need to understand what those terms are and plan for the payback of any unpaid or deferred rent, utilities, vendor invoices. Many of us have applied for either the Medicare Advanced Payment Program or there are now some advanced payment programs by the commercial payers. And so what are those payment requirements? With CMS, as you know, they're going to claw back 100% of future claims starting on day 121. And so what will that mean from a cash flow perspective? And if you've tapped any lines of credit, you'll need to pay back those lines as well. For the SBA 7A PPP forgivable loan, remember that only a portion of those loans are forgivable under the terms that haven't yet been defined by the government. So you'll need to pay back a certain portion. Be sure to account for that percentage and the terms of those requirements as you build your financial forecast. And don't forget that you'll have reporting requirements for any federal funds that you've received. So start making a list of those requirements and deadlines when they're known so that you have a mechanism to track the compliance portion of those requirements. And you should still expect a significant volume reduction to continue for the foreseeable future. Open doesn't mean that we're going to be busy. I expect elective case volume, particularly procedural volume, will continue to be reduced due to either a lack of sufficient PPE supplies, medication shortages, or just patients who are uncomfortable walking into a medical practice unless absolutely necessary. This may be particularly true for hospital-based outpatient practices where entrances to the outpatient setting are sometimes shared between the outpatient and urgent care locations. I know that there are a lot of gastroenterology practices on the call. So for practices like these that own and operate ancillary practices or divisions such as anesthesia, outpatient surgical centers, laboratories, et cetera, don't forget about developing systems and plans for those businesses too, not just your core GI practice. Alternatively, if you rely on other practices as suppliers to your practice, example, you outsource anesthesia, as in my case, be sure to share your volume forecasts and staffing plans with them so that they can prepare to cover your facilities as you begin ramping up. You'll also want to review any contracts that you have with suppliers or vendors. Are there minimum payment requirements, minimum order thresholds, et cetera? If you've stopped a collections activity, either on patient accounts held in-house or through your third-party collection agency, be sure you restart that activity. And you'll want to review your processes for approving write-offs or payment plans, given the number of people who have become unemployed. And please don't groan at my next recommendation, but it's critical that you develop a budget with assumptions regarding anticipated volume, collections using historical DSO, and payback of deferments. If you have prior experience in starting a new practice or service line, that's going to be probably the most valuable experience from which to draw upon over the next few months. So review any startup documents that you might have prepared then for a head start on the work that you're going to need to do. And if you haven't developed a new practice pro forma and don't have an internal finance manager, you can get help from your company's accountant. Alternatively, if you use a billing or management company, they may be able to assist as well. And even if you get help from other team members or outside assistance, the data inputs are going to be critical. So be sure to think diligently about the volume and ramp-up schedule that you expect. Modify those adjustments, those data points as needed, and consult with your physician leadership to validate the assumptions that you're making. And remember, cash is going to be delayed. So using historical DSO may be helpful here in understanding that you're going to have expenses in the first several months of the practice restarting without any revenue coming in the door. And I'd be remiss if I didn't really talk about the elephant in the room. Our physician shareholders have either reduced their draw significantly or reduced it to zero in order to be able to pay staff and keep the lights on. One question that we'll need to ask ourselves is, how do we compensate physicians who have worked in an eat what you kill model in a post-COVID-19 environment? How are physician shareholders who are at high risk for contracting the virus compensated if they don't work in the office or don't perform procedures, but rather simply refer cases to their partners? Will older physicians discuss early retirement options? Or will the practice force those conversations to occur? And if they do retire, how will you handle the buyouts of those physicians who are leaving the practice? Can you pay those payments over time? You'll need to check your bylaws or operating agreements because often the payout requirements are specified in those legal documents. And if they're not pro-practice, but were originally written to be pro-physician, you may want to talk with legal counsel about modifying those agreements now in advance of an influx of physicians retiring from your practice. And if you're like my practice, you've either furloughed or laid off most of your staff. So on the human resources front, you're going to want to begin considering how you plan on bringing your workforce back to work. Will you need the same number and the same type of employees, especially if volume is going to be reduced for some period of time? Will you need to reduce compensation for the staff that are retained? If physical distancing will become the norm, which I think we all agree will, then the space in your offices, think about the medical assistant workstations and the break rooms, are likely insufficient to meet those requirements. And what kind of testing capabilities would your practice need to safely care for patients and bring in staff? Will we have access to point-of-care testing for coronavirus? Are daily temperature checks helpful to determine if an employee can work? To assist with the earlier issue of maintaining physical separation of your workforce, you'll likely want to consider maintaining telecommuting of non-patient-facing staff. But if you haven't already done this, you'll need to develop systems to monitor those employees to ensure that work is actually being performed. For your on-site personnel, you might want to consider placing them on rotating teams. Our endoscopy centers, for example, are currently doing this for our urgent cases. Essentially, if a member of the team, any one member of the team, becomes ill with coronavirus-like symptoms, whether or not that staff member tests positive, given that there aren't sufficient testing and that there are a lot of false negatives, the entire team self-quarantines for 14 days. Do you have enough staff to do this? Will patient volume support this kind of plan? What about staff and physicians who are over the age of 60 and or have underlying health issues? Will you be asked to make a reasonable accommodation for their safety? This is an area of employment law that will be tested in the coming months for sure. And if you haven't begun considering the reasonable accommodation requests that may be coming from staff as you reopen, you should. Some operational issues that you'll want to consider as you plan to reopen include the continued need for supplies and equipment like PPE. You'll want to understand your volume assumptions so that you can conduct the correct financial analysis, but more importantly, right-size the workforce that you'll need and operationally determine the PAR levels for the inventory that you'll require. We talked about physical separation for employees and workspaces in the break room, but have you started to consider physical separation of patients, for example, in your waiting room? What are the sanitation and sterilization techniques that you'll need to conduct between visits? And how much time does that take so that you can appropriately schedule visits? With most offices closed, have you enacted a plan to maintain any sensitive equipment today to ensure that they'll be functioning when you reopen? And finally, what supplies and equipment do you need? You'll want to check with your vendors about their continued ability to provide you with what you need and find backup vendors as soon as possible, particularly as it relates to PPE. Either due to pent-up demand for services during this period of pause or due to physical distancing requirements, you should begin considering how you'll schedule patients, both in terms of the block of time required for a scheduled appointment and any cleaning, but also potentially extending service hours into the evening or the weekend. If you're planning on an extended period of time for the services, consider breaking staff up into shifts. And as more practices have started offering telehealth out of necessity, patients are becoming used to the service. And it's likely that patients will want to continue being offered that service moving forward. Have you thought about how to integrate telehealth when you're quote unquote open? What if telehealth service reimbursement is reduced when the regulatory changes that were enacted revert back? For procedural practices, the increased use of ventilators to treat coronavirus patients have significantly reduced the availability of certain medications, including propofol, fentanyl, Versed. If your practice is dependent on any of these drugs or others that are in short supply, what's your plan to acquire these drugs? And if you're not able to obtain them, how does this impact your volume and financial projections? And finally, have you considered how you're going to screen and or test your patients? We talked about screening or testing employees and staff before, but absent point-of-care testing capabilities, what procedures will you develop to screen those patients? Will you have someone check temperatures at check-in? Will you conduct pre-visit health assessments by telephone? And or how will you know whether someone presents to your office who might otherwise be better served either at home or in some other setting? So sadly, I realize that I likely have given you a lot more to think about with my questions than I provided you with answers. But as I said in the beginning of the conversation, we're in uncharted territory. One of the things that I've learned in my professional career is that it's not what questions you ask, but what questions you didn't ask that will keep you up at night and that will cause you the most pain later. I'm in the same position as you are, navigating a ship without a compass, today just trying to survive. And before we open up the presentation to questions, I want to offer a couple of final thoughts. So, Mr. Rogers of 1980s TV fame and the land of make-believe has a famous quote that I'm sure you've heard before. When I was a boy and I would see scary things in the news, my mom would say to me, look for the helpers. You'll always find people who are helping. And that statement is just as true today. And to that end, I'd like to thank all of our essential workers who leave their homes every day to care for us, whether in hospitals, practices, or pharmacies, or those who are part of our food chain supply. And with that, happy to answer any questions you might have.
Great. Thank you so much for your presentation, Brian. If anyone has any questions, you may type them now in the question box located on the right of your screen. So the first question is, what tasks can or should be outsourced?
Great question. What tasks should or could be outsourced? I think this is really going to be a little dependent on what the cost of those services are and the ease by which you can get those services outsourced if you haven't done so already. So one would think of sort of billing and collections as sort of one of those services that could be outsourced and could probably be done cheaper by outsourcing the service than by doing it in-house. And the reason I say that is for most billing and collections companies, you're paying a percentage of collections for that activity. And so the other entity, your billing company, would have all of the fixed costs that you currently have on your balance sheet. They would absorb that and you would simply pay a percentage of the collection. So in a practice like mine that does outsource, we found that one decision that we made 11 years ago when we started our practice has actually helped us weather the storm, because I didn't have employees on staff that I was required to pay. And now that cash has diminished and collections have diminished, I'm only paying a very small amount every month for that service. So I would think about anything that can easily be done by somebody else to absorb expenses that you're currently carrying on your P&L that somebody else could carry, and look to outsource those. And I would start with those that cost you the most on a monthly basis.
Thank you. The next question is, the Paycheck Protection Loan forgiveness requires maintaining the same number of employees during the 8-week period after the loan. How does this fit into staff planning?
Yeah, great question. Remember that requirement is for the forgiveness program requirements. There's still a lot that's not yet known about the program. For example, I don't know how you're expected to spend 2.5 months of payments in 2 months. The math just doesn't work if you're a practice that doesn't have rent or other expenses, for example. So part of the question here will be maintaining staff for the purpose of the forgiveness, or foregoing some of the forgiveness because it's actually cheaper in the long run. So that's a balance that you're going to have to decide. Hopefully, when we get better guidance on the PPP program and the write-off requirements, that will help answer the question. But for at minimum the 8 weeks, and remember it's 8 weeks from when you get the money, you could maintain the same staff. The question will be, what do you do after that 8 weeks if that money is truly free?
Thank you. The next question is, Brian, I'm so sorry for your loss and thank you for this webinar. What is the longest time to get back to normal?
Thanks for that. I wanted to include Danny's photo really just to personalize this, because the numbers in aggregate are stunning, but they're not really impactful. I don't think, unless it really touches you or someone that you know. And so by sharing that, I just wanted to be able to demonstrate that, but I appreciate the comment. I don't know how long normal, when we return to normal. I would expect that we will operate at slim margins for the next 12 months to 2 years. I don't think we go back to sort of large distributions for shareholders for a considerable amount of time. You have to realize that with the continued physical distancing, with the continued concern about being out in public, that every industry, and particularly ours, is going to be impacted, because there are so many costs that are fixed right now for which we don't have any control. You think about rent. Unless you own your own building and can reduce your rental cost to just the mortgage value, you're going to be paying for space that you may not need anymore, because you're going to be either you'll have fewer employees or you'll allow them to work from home.
Next question is, what types of visits lend to telehealth long term? What specialties?
Great question. I think we're all learning what services can be provided via telehealth. Essentially, anything that doesn't require a physical exam right now can be done via telehealth. The concern is for certain diagnoses and treatments, physicians and advanced practice clinicians need to put their hands on patients to diagnose and treat. And so I think technology may help us. We're not there yet as a country. We're not there as individual medical practices, particularly smaller ones, to have access to those, to that. I think in some ways, the physical exam portion of the visit is going to be conducted by the patient, him or herself, reporting what they feel, which isn't perfect. So I think every specialty is going to be forced to use telehealth more than they predicted in the past. And I think that patients are really going to be a little leery about waiting in a waiting room with other patients who they don't know, who are quote unquote sick, whether it's coronavirus or not. So how do you prepare for that, and how do you provide care for patients when you may not be able to physically see them in person.
Okay, the next question is, have you given any thought to associate physicians on a contract for reduction of salary?
Great question. Depending on the contract terms, if there are suspension or modification clauses, in most contracts, including employment contracts, most will have language that says that they can be modified by mutual agreement of the parties. And otherwise, there's usually a term or termination clause. And so I would have an honest conversation with those providers, if you haven't already, to discuss a salary reduction. The other thing that you need to consider is that if you don't have the patient volume and you don't need the number of staff that you had before, will you need the number of providers that you had before? And so if this really goes 12 to 18 months in sort of this limbo of life, then reducing all of your staffing, including your providers, may be necessary to survive. I think some of this will be balanced with if you have shareholder retirements that happen earlier, maybe you rely on those employed or contracted providers to help balance out the need. But that's where really we're starting with volume, and assumptions related to your ramp up will be helpful for you to right size the number of providers that you'll need. Remembering that it's not just the number of providers and the number of patients, but also the duration of time of those visits. Those 10-minute dermatology visits that we would stack, 15, 20 patients an hour, I think those days are gone just based on the cleaning and sterilization techniques that we're going to need to do between visits.
What do you plan to do if your practice passes over 3 state lines and proposes different rules of engagement?
So, great question. You're going to have regulatory issues that may vary between the 3 states. And so one thing that they've made easier right now is the temporary licensure across state lines. So if you haven't taken advantage of that, do that. And I would also think about, as you develop your financial plans, develop the financial plans for each location and then do a roll up into a total company P&L. So treat each location as if it were its own business. And you'll need to make important decisions, I think, of whether you keep all practice locations open or not. It may be far better to close a location financially and operationally than keeping every location open, at least for some period of time. But great question. The regulatory issues between states will become problematic. It already was before, right? But as they start relaxing or undoing the relaxing of the regulatory changes that they've made, you may find that there's variation between the states that then makes it more difficult to plan in one place or another.
What do you think about PPP loans if there are not too many patients and revenue coming in?
So the Paycheck Protection Program loan doesn't have any requirements related to the volume. I think your question is really what happens if after the 2 months that money is run dry, you have to keep employees paid through the next quarter, I think is a period of time. If you take out the PPP loan, which I think we all have at this point, you'll want to keep enough cash reserves to pay any of the required payments for that period of time in order to satisfy that requirement. So it's not just about getting an influx of cash today. It's really thinking about what the requirements are for the forgiveness portion or the payback portion in the case of the CMS Advanced Payment Program, so that you actually can weather the storm. Because right now, what I'm hearing is that a lot of practices are applying for all these funds in order to keep the lights on. That's great, but you shouldn't do that at the risk of just forgetting about the inevitable and not being able to pay back anything that needs to be paid back, or any portion that might not be forgiven. So I would, if you haven't really reduced expenses as much as you can, you need to do that immediately. And you need to reserve in cash any potential financial outlay that you have related to any agreement that you've signed with the federal government.
Thank you. The next question was, thank you for your time and expertise. One question I have is if you have any resources regarding the startup of telemedicine/telehealth.
So I don't personally have resources related to starting telehealth. I will tell you that what I know is that a lot of the restrictions that we had before have been lifted in terms of being able to use sort of relatively unsecure mechanisms like FaceTime, et cetera. I would first check with your state affiliate MGMAs. There has been a lot of activity over the last 2 or 3 weeks on telehealth, and all of those webinars like this one have been archived. So many of the early ones focused on how to get started in telehealth if you weren't already doing it. And then there's one being offered tomorrow by the state affiliates that Dawn Wilno and her team at CORE is doing. So that's all of New England, New Jersey, Maryland, Nevada, and California on coding requirements for telehealth. So I would check with the state MGMA resources. All of the states that we're affiliated with have opened up all of their coronavirus pandemic resources for free, so you don't have to be a member to participate. And so I would check with those resources.
Thank you. And I may as well add that we do have a corporate sponsor in here, Medmo, that did say if we have any service questions that Medmo will facilitate all medical imaging appointments, prior authorizations, scheduling for free for 12 months as a part of their COVID program. And that is Medmo.
Thanks,
so
Maria.
The next question is, for staff over 60, why would we consider this classification as a risk, as the numbers have shown that most COVID-19 sufferers were below the age of 60?
Great question. And this is my guess. It's not what is out there. But if you read some of the plans to reopen the country, and this is now true of state governments as well, the risk factor for significant disease and death is largely related to the over 60 and the underlying comorbidity groups. While there have been a lot of people under the age of 60 who've contracted it, and some of those have died as well, the primary risk group is still the older or underlying health conditions. And so my concern and the question that we're going to have to grapple with is, if the recommendation is that people over the age of 60 and those with underlying medical conditions, quote unquote, stay at home as much as possible, what does that mean from an employment perspective? What does that mean from a legal requirement of, if you're asked by an older employee or somebody with an underlying medical condition to make a reasonable accommodation to work from home, can they? Are there other reasonable accommodations that you can make to keep them safe in the workforce? So it's two parts, right? One, is that going to be the recommendation? Because if it's not, then it's a moot point. But if it is a recommendation, then what are the employment law requirements and responsibilities of the employer if a claim is made for a reasonable accommodation? I don't know the answer. I haven't heard this brought up in any other presentation or conversation I've had. It's just one thing that I've thought of. In my practice, we have a number of older or underlying health condition staff members, frontline staff members. And so I'm concerned about that, depending on the number and depending on what those reasonable requirements might look like.
Thank you. Will payment plans be an important part of helping cash flow? Should I offer those?
It's a great question. It's a catch-22 because you're going to need the cash just as desperately as your patients are going to want to preserve cash. So you're both fighting for the same thing and competing with one another for it. there's no right answer here. In the beginning, my practice decided that we were not sending any patient statements out. We knew that it was going to get bad from a unemployment perspective, and even if our patients weren't directly related, the last thing I wanted to have happen is my practice be on the front page of the Washington Post saying that I was chasing down grandma for her $30 deductible when she couldn't afford to buy food. So we froze all patient statements temporarily. I think you need to strike a balance, though. And so if people are affected directly as it relates to either reduced compensation or furlough or layoff, then I think it's perfectly appropriate to work with them with payment plans. If somebody's still gainfully employed and they don't need that relief, then maybe not. But that's why I think you need to review your policies and determine, what kind of documentation you might require from those patients who are asking for some kind of temporary relief.
Okay, the next question is, I know it is hard to tell, but do you think scheduling patients by mid-May is a realistic in primary internal medicine practice?
Great question. We're all guessing. I think that's probably the right time. Mid to late May is probably realistic. I think you should start planning for, and again, I think this is going to be based on geography, right? So if you're in California or Washington, Oregon, we'll find out today what the plan is for the West Coast, because they're going to open up as a region. So I think we'll have a little bit more guidance in the next week or so, both from the federal government and also from the state governors. So I think planning for a date is great, recognizing that you may need to be flexible, moving that up or back depending on what's happening in your specific geographic location. I think if you're in New York City, that's going to be a lot harder and would be a lot more incremental than, say, if you were, in Nevada, for example.
Do you have any insight on whether practices will continue to be able to do telehealth services post-COVID-19?
So certainly you can do it post-COVID-19 because you were able to do it before. I think the better question and what you may be asking is, will you get reimbursed the full value of what you were getting paid for an in-office visit? And that I don't know. I would hope and trust that just like CMS temporarily raised the telehealth reimbursement to match the in-office reimbursement, that as long as the physical distancing recommendations are still out there, that CMS would honor that so that at least you're getting paid equally to what you would get paid in an office setting. Maybe there's a slight reduction down because from a coding requirement, you can't code for that office visit the same way you would if the patient was physically in front of you. So can you do it? Absolutely. You should plan on doing it. Will you get reimbursed the same? I don't know. I would conservatively estimate 85% reimbursement of what you're currently getting on those telehealth visits, expecting that reimbursement to be brought down. If it's not, then it's found money in the P&L. But from a planning perspective, I don't think we're going to go back to pre-COVID reimbursement for telehealth, but I do think it will eventually be reduced to have some distinction between in-office versus telehealth, just based on the relative expenses related to that service being provided, where you don't need the physical space even though you have it already.
With regard to the PPP for loan forgiveness, what happens if a portion of the staff just doesn't return because they choose that? Will that affect the forgiveness portion?
Great question. I've been asking that for weeks. I've not seen any guidance on that yet. I think some of this will be the spirit of the law. So if you offer the job, and as long as that job is, within a certain percentage of what their former compensation was, then I think it will be forgiven. I don't know that for certain. I also don't think, given the number of people that are unemployed in the country right now, and that number is going to rise, I don't see people making big life changes. I don't see people taking another job or going down the street for a quarter more an hour like we used to see. I really think that people are going to stay put where they can. So I don't think there's a lot of risk to people jumping ship and going to another practice or leaving work. I don't think that's going to be the problem. It might be, but I think if it is, then as long as you can demonstrate that you had a job available, I think the government will consider that a checkbox for you. The government has moved at amazing pace, and even the OIG, who is not very friendly, has said that as long as you follow the spirit of what the laws or regulations are intending during this period, that there won't be repercussions. So if the OIG is saying that from a regulatory and an enforcement perspective, I would think that from a financial perspective, CMS and the other regulatory agencies would follow the same logic. Again, I don't know, but I suspect that because we're in uncharted territory, that would be the case. Follow the spirit, offer the job. If they don't, I think you have a good argument for it still being forgiven.
Thank you. Should we require patients to wear face masks?
Yeah.
So masks are now the recommendation across the country. In certain jurisdictions, like where I am in Palm Springs, California, it's required when you leave your home that you wear a mask. So yes, I think that masks are going to be either one of those things that are required when you're in public or strongly recommended. I think if you're on mass transit, they will be required. I think in your practice, it is both from a visual perspective of demonstrating good decision making and following rules. You should be doing it. I think the question will be, how do you have supplies? What happens if a patient comes in without a mask, et cetera? But the guidance from HHS has now been clear that they recommend people wear masks in public at all times for the foreseeable future.
You mentioned rotating teams when working. Isn't it better to keep the same team so if someone was to contract the virus, they only have been in contact with the same employees? Or did you mean rotate the same teams into the office at different intervals?
Great question. Yes, I meant rotate the same team. So keep that team consistent. So provider A, nurse B, MA C, front desk D, they operate as a team. They either work every day for a week, every third day, whatever that rotation is. But yes, keeping that team cohesive. We've been able to do that in our endoscopy centers to some extent. And that's worked out very, very well. I imagine we're going to want to continue that until there's widespread testing capabilities available. Once we get to the point of care testing, I think some of that goes away because we'll have more rapid responses. But we don't have the test kits. We don't have the testing capabilities. We're producing maybe 1 million tests per week, but there are 350 odd million Americans, and that's just one time, right? If you're going to need to test people every day, you're going to need billions and billions of tests, and we don't have that.
Does maintaining the same number of employees for the SBA mean same employee hours, or can you reduce hours and not reduce the number of employees allowed?
Great question. The only guidance I've seen so far, and I'm not an expert, I've attended many of the same webinars that you have. The only guidance that I've seen is related to the reduction in salary. You're allowed to reduce an employee's salary, I think, up to 25%, but no greater, and still have that portion forgiven. I don't know whether there are hours associated with it. I don't know. It's really just keep the people and don't reduce their salary by more than 25% that I've seen. There might be additional guidance, but I don't know that I've seen that if there is.
Patients are losing their insurance through layoffs, and they increasingly are turning down telehealth. Do you have any suggestions?
Yeah, so this is going to be one of the next problems that we face as a country. COBRA is not affordable for most people as a recourse when they get laid off. So the question will be, if they're unemployed, this is a qualifying event for getting insurance through the exchange. Whether they can afford that or not will be a different question. And so if they can't afford that, then what are your cash payment options for those patients? And so that's what I would start thinking about. You will have more unemployed. You will have more self-pay. You will need to think about your fee schedule for self-pay patients. And you're going to need to think about how you collect that money in advance of that telehealth visit, just like you would for the copay or if it was a self-pay patient, the deposit or even the full payment at check-in, right? So what's your virtual check-in going to look like for those telehealth visits for the uninsured? Good question.
What is your opinion? What could be the single largest impact on our country's providers' availability from this COVID crisis?
I think the single biggest impact of availability will be the number of providers who were close to retirement, who decide that it's just not worth it to keep practicing. And whether that's an independent doc in a small practice who closes her shop, or whether that's a large practice that reduces, by 10 to 20% of their physician or advanced practitioner workforce. I think access to healthcare is going to be harder because the number of providers, I think, inherently will go down. I might be wrong because for all of us, we took a significant economic impact in the market. And so maybe they need to extend that time of working. But I think they're going to balance that decision with the potential risk factor if they're older of returning to work. So I think that's one issue. I think the economic impact and the insurance-related question that was just asked will be sort of the second most impactful component. Will people be able to pay, even if they are insured, their copayment or coinsurance or deductible? We were already having so many problems with patient financial responsibility on the portion that they were required to pay when they were, quote unquote, gainfully employed, largely because they had high deductible plans, that now when you factor in all the economic impact of this, that's going to be a lot harder to collect. So money is going to be a lot harder to chase down.
Thank you. Have you given any thoughts around additional revenue options for the practices, for example, allergy program?
It's a great question. So I have a client that was prepared to go live on May 4th with a new ancillary service. And they were gung-ho. We'd started hiring providers to provide the service. And we put a pause on that. And so the balance I think that you're going to have to ask yourself in looking at new service lines to add new revenue to your practices, what's the upfront cost to provide that service? Remember that if you're starting a new service, you're going to have, just like in the pro forma that you're developing for the startup of your practice now, you're going to have a pro forma with delayed collections for that new ancillary service for 30, 60, maybe 90 days for some payers. And so you're going to have a financial outlay of, at minimum, payroll expense of personnel and or providers who are really expensive for some period of time, at a time when cash is really critical and low. So while it's a great idea and you should consider it, I'd be cautious at opening up any new service lines at this time. Because of the outflow of cash. In fact, my recommendation to my client was that they continue to delay the startup of that ancillary until we have a little bit more clarity, because they've already taken salary reductions, they furloughed a lot of their staff. And so, yes, they would potentially make more money down the road from the ancillary. The question is, at what financial expense in the short term, and can they afford it? How do you have physicians start up a new division or a new service line or a new company and have a capital call for the startup expenses when you haven't paid yourself for 2 or 3 months? And or are you just going to borrow from somewhere else to fund that startup? And then what are the payback requirements? So it's certainly something to consider, and expanding the practice in order to increase revenue is a great idea. But just be careful that the cost of doing that can be quickly recouped, and that you don't have to burn up valuable capital today that you may have to do that.
Okay, the next question is, does the CARES Act money only apply to physicians directly caring for COVID-19 patients, or for all physicians impacted by COVID-19? Since the government is sending the money first and then asking us to certify how we are complying with the terms of the Act.
That is the $30 billion question, and nobody knows the answer to that question yet. So here's the good news. So HHS made the payments, divided the $30 billion up starting last Friday. My practice got our share on Friday. It was great. We had the money. I put it in the bank account. We're not touching it until we can review all the final terms and conditions. The language that you're referencing is concerning to me, because I think many practices, based on how it's written today, may not qualify or may have a hard time justifying that they can attest to it. But here's the good news. There's going to be additional guidance coming out this week for the attestation. And my understanding is that you have 30 days from when that is, from either when you receive the money or when the attestation document is released. But either way, it's within a couple of days. So you're talking about 25 days, say, from today, to either attest or give that money back. So we'll get more guidance in the next several weeks. This question has been asked a lot. MGMA National's Government Affairs Committee has already relayed this exact concern to HHS. They understand that they're going to need to provide more guidance. And so I would expect in the next week that we'll get more guidance. The spirit of the money was intended to give immediate relief to all medical practices. But the language that you're referring to is concerning, because it directly relates to caring for patients with possible or confirmed coronavirus, which I think is where the hiccup is that we have right now. I don't know the answer. We'll get it soon, and your state MGMA chapter will certainly share that information with you when it's released, because that is the burning question right now. In the meantime, don't spend the money. Keep it in the bank, keep it separate, and be prepared financially to refund that if necessary to the government within the next 30 days.
Thank you. Some paid employees at the lower end of the scale will make more money on unemployment than on reduced pay when hired back. How best to handle that scenario?
Yeah, there's nothing that you can do about that. At the end of the day, the extra $600 per week for 16 weeks of federal unemployment assistance that's been granted to the states was really meant as a safety net to make sure that people could purchase groceries, pay their rent, et cetera. And it was really unprecedented action by the government. At the end of the day, though, after 4 months, that eliminates and goes back down to just whatever the state maximum weekly payment is, or whatever their pro rata share is based on their salary. So it's a short-lived a bump in salary. I think the question really is related to, okay, Brian, that's 16 weeks, but what happens if I open my practice in 4 weeks? They would effectively be foregoing 12 weeks of additional compensation. You're right. And so the risk that those employees run is either they come back to work and they make less money compared to unemployment, but they're employed, or they're laid off. Their health insurance goes away, which wouldn't be enough long term to sustain the difference in the unemployment check, and they'd have to find a new job when 20 million people are unemployed. So I don't think we're going to see our workforce, our lower wage earners, asking for more compensation when they come back, or staying on the unemployment books in order to benefit from the $600 per week for 16 weeks. I think most people realize that that's short money, and that the being able to return to work and getting a guaranteed paycheck, even if it's less than what your temporary money received from unemployment is still going to be a better deal for people in the long run. And if they don't come back and you don't need them anyway, then it saved you from making a difficult decision of which employee to keep or not.
The next question is, did I understand you correctly when you said in the beginning that it is still being determined whether we will be able to keep the HHS funds that were deposited into our bank accounts on April 10th? The second part of my question is whether the attestation portal to acknowledge receipts of these funds is open.
So I think I answered that question just a moment ago. So the terms and condition language is confusing, and it's unclear, in my opinion, whether all practices qualify to keep the money based on the language written in terms and conditions. We'll get more clarity, I think, in the next week, which will help answer that question. The portal is not yet open. It's scheduled to open this week. I checked this morning right before coming on. I did not see it open yet. And I think based on the questions that we've asked MGMA National's legislative office to address to HHS, that portal will not be open until we get clarity about it. But I would expect this to happen quickly in the next week.
Thank you. And I do want to add that I know we are at the end of our scheduled hour, so if anyone has to hop off the webinar, that is okay. The recording will be available, including this Q&A session, as we answer all of the rest of the questions. So the next question is the 8-week forgiveness in effect as long as you rehire employees by June 30th? For example, if you rehire employees June 20th and you received the loan today, is the loan still forgiven as long as you use the loan for the spelled out reasons?
Good question. And again, I know that there's a lot of information, and some of which is conflicting information, particularly because the guidelines changed a lot. But my understanding is that you have to spend the funds within the immediate 8-week period after you receive it. I may be mistaken on that, but I don't think I am. If that's the case, then that changes the timeline tremendously for you. The intent of the PPP was to keep people on the payroll, not to have them furloughed, not to have them on unemployment. And so if that's the case, then it would make sense the government would want you to spend the money as soon as you received it, because it was really intended for the people that you kept, not for the people that you furloughed. So the question, I think, is if you furloughed people and you receive the money today, do you bring them back today for that 8 weeks? And then if you still don't need them after the 8 weeks, whether you furlough them again. That may be what you need to do. But I would check with your lender on those requirements, and on the SBA website. There's going to be a lot more guidance on this as the SBA loans are approved and the money's dispersed. But great questions. You know, the reality here is that the government acted to spend a fortune of money, but didn't think through and didn't have time, frankly, to think through all of these level of details. You're asking great questions. There just isn't a lot of clarity around some of these topics.
Do you have a feel for whether or not CMS will take back coverage for telehealth?
I don't. Look, CMS can do anything, right? But I don't think they will take away coverage for a lot of reasons, but mostly from a public safety, public health perspective. It's safer to provide care to patients at home, and you don't want people traveling unnecessarily. So if I were a betting man, and I don't go to casinos and spend money, so I'm not the right person to ask this question, but I would imagine that reimbursement will stay the same for telehealth for the foreseeable future. I don't think we're going to see reductions. I don't think we're going to see a tightening of regulation around telehealth other than wanting to ensure secure communication. So I think some of the restrictions that were laxed temporarily related to like FaceTime and unsecure methods of communicating. I think that will change. So if you haven't yet thought about how you're going to communicate with patients securely via telehealth, that's one area that you need to spend time on today, because I think those restrictions will be firmed up soon.
All right, so the next question is, I am a compliance officer. I am concerned, although having a compliance professional is a requirement for an effective compliance program and a requirement for CMS. Although compliance is involved with all aspects of the practice, but since it may be looked at as an added expense, may be let go. But in the long run, compliance will save the organization impossible fines and is critical in making sure laws and policy are followed and training provided for the organization. Do you think if not having compliance could put the organization at a greater risk?
I do. I think, there are so many regulatory changes that have been made so rapidly. So CMS in large part has relaxed so many restrictions that we were previously under just 5 weeks ago. They're going to begin rolling back some of those, and maintaining an understanding of what the then current or now current regulatory environment is going to be important. So to the extent to which you're responsible for that activity, I think that's going to be critical. I also think that from a compliance perspective, there are reporting requirements that the federal government is going to require for all of these programs. And so what are those requirements, and how are you reporting those? I think part of the question for yours is obviously job security, right? We're all concerned about job security. And so I think the way to reconcile that is some things are just out of your control, but then making yourself valuable to the company in ways that you didn't think about before is really going to be what separates you and or your position, I think, from somebody else. But demonstrating your value, particularly if you are in one of those positions that could be outsourced and could be, quote unquote, more easily or economically outsourced, is really going to be one of the things that you can do to protect yourself personally, professionally.
Thank you. The next question is, I just received the PPP loan. The PPP funding was based on the full-time payroll expenses for the past 12 months. However, they do not reflect the increased payroll costs for me in 2020. To be able to just use the forgivable amounts, I would have to keep the staff employed on reduced hours. But PPP requires us to engage them on a full-time basis for these 8 weeks. How do I balance the requirements with the reality?
Yeah, and so this is one of the issues with the regulations and how they're written, and I think that for many practices, a large portion of the PPP will be forgiven, but perhaps not all of the payroll portion of it, just based on the economics of needing to reduce the hours and like. So I think clawing back a portion of the PPP, and I don't know the right percentage to claw back, but reserving a portion of the dollars that you were given in order to have money to pay back the unforgivable portion down the road will be forgiven. I wouldn't take it from the PPP money. I would take that percentage from other funds, other operating account that you have, but reserving that, I think, is going to be important. For many practices, you're talking about hundreds of thousands of dollars or millions of dollars, depending on the size of your practice, of PPP loan, of which the forgiveness requirements are just broad strokes of definitions without a lot of specificity. We'll get more, but of course we'll get more after we've been required to spend a lot of the money. So yeah, I don't know those answers. You're right. It only impacts you're looking at 2019 salaries. So if you are on a calendar year, if you did cost of living increases, let's say December 31st for January 1, you're not getting credit for that differential in payment today, which I think is where the federal government realized that keeping it at 100% of then compensation wasn't necessarily going to be pragmatic, and that's why you had to keep salaries at 75%. But that brings up the whole other question of then, if you're only paying somebody at 75%, how do you spend all of it in the 8 weeks? I don't know. The answer to that is really that some of it may not be forgiven.
If furlough staff turn down the callback, do they get terminated by us, and do they remain on unemployment?
Great question. I'm not an attorney, which is how I probably should have started the presentation. So I would check with your employment attorney. My armchair quarterback answer to that would be that they would be terminated. And I imagine that unemployment benefits in most states would be pretty lax in terms of who qualifies. I don't know that for certain. But I can't imagine, given the economic environment that we're in, people being arbitrarily, well, not really arbitrarily, but taking off the unemployment rolls just because they didn't return to work. There are going to be factors and circumstances that somebody may not want to return to work. I bring up the underlying medical conditions. If you're not able to do a reasonable accommodation and they don't feel safe, I think that's going to be a way in which they're going to be able to keep their unemployment benefits. But again, I'm not a labor and employment attorney, and sadly, and there are attorneys on the call, I presume, attorneys always are the one group of people who make money. So you're going to have to call one.
Any advice for dealing with landlords who want us to continue paying rent, yet we are only seeing 30% of our usual patient load? So far, there are only moratoriums placed on residential.
Yeah, great question. I think some of it depends on the jurisdiction. So in Palm Springs, California, there are moratoriums both on residential and commercial property, believe it or not. So some of this is jurisdiction by jurisdiction, and yours it isn't. That's clear. I think having an honest conversation with your landlord and or the management company is going to be important. I think, I mentioned earlier that you're going to have to take a look at all your contracts. Well, that includes your rental agreements, your leases. That includes all of your supplies and equipment and vendor relationships for suppliers to maintain equipment as well. You're going to have to renegotiate all of those terms and conditions. And in large part, I think most people will end up doing the right thing. Worst case scenario, for your landlord is if you can't pay the bill and you go out of business because they're forcing you to pay the full rent, then they're not going to get anything. And something today is better than nothing. So I would start having those conversations if you haven't already to explain to them what your revenue projections are going to look like, because you're going to have those. And rent is going to be one of the expenses on that pro forma that you develop, and to be able to say that we can't afford that because we've taken a 50% reduction in volume or 60% reduction in revenue, those numbers are going to be important, as opposed to just saying we're seeing fewer patients and therefore I can't pay you. Having those percentages in the conversations with your landlord, I think, will be helpful.
Will you consider outsourcing medical billing and coding an option for reducing overhead while improving income?
Yeah, so I addressed that earlier in the presentation. I think that's one option. The concerns that I have, though, related to that is if you're not doing it currently, there's a transaction cost to transitioning to that. And so it will take time for that billing and management company to get up to speed. There may be some delays in cash posting or claims processing at a time when you really need cash to come in quickly. I also have concerns about the viability of some of these companies in the same way that we have concerns about the viability of our practice. So you're going to want to understand the ways in which they've mitigated their financial exposure. Do they have enough staff to do the increased work if you and 10 other practices want to sign up tomorrow? So it's a balancing act here. It may save you on a percentage of collections by outsourcing it, and you go from a fixed cost to a variable cost. but at what expense and at what risk? So the answer is maybe.
What if you have an employee that is performing poorly? Do you have to keep them since you are taking the PPP loan?
Yes. So again, not an attorney, but this answer is always true. You cannot use this time as an opportunity to fire an employee. You will do more harm than good in doing that. So forget about an employee's performance in the past as it relates to determining who you keep furloughed or lay off. That cannot enter into the conversation. Do it based on function area, do it based on need of the practice, do it based on the changing need of the practice, but do not do it based on performance improvement plans, poor attitude, etc. Take all of those elements that you would normally use in a progressive discipline process out of the equation entirely. You are setting yourself up for at minimum a headache, and at worst a legal lawsuit that you just don't need.
We have kept our allergy immunology program in place, but the recommendations are to reduce the frequency patients should come in. How do we keep them on their regimen without going backwards?
Yeah, so I'm not a clinician, just like I'm not an attorney, and I don't know a lot about the allergy specialty. So I would defer those types of questions to your clinical professional societies. They're going to be the best resource for those types of questions. I participate in the American Society of Anesthesiologists webinars. I'm on the ASGE webinars for gastrointestinal endoscopy and GI docs. Those have really been very valuable from a clinical perspective in terms of how to care for patients safely. So I would refer you back to your medical professional societies that are out there that will help provide you with that guidance.
Do you have any suggestions on what an over 60 physician could do to remain productive if they took retirement to help the practice?
Yeah, so if you have an older physician shareholder who's willing to quote unquote retire and then come back as an employed doc, that's one way many practices can consider reducing the financial burden on the shareholder balance sheet. I think the challenge is going to be what work can those providers do if they either don't want to be in front of a patient in the office or can't. So can they do telehealth? And not to be stereotypical, but in the GI practice that I work with, they weren't prepared yet for telehealth. And a lot of the older docs simply weren't technologically savvy enough to be able to do some of the work. So I think those are sort of the tough questions out there, that it's not just a matter of willingness to work, but a capability of working, either physically coming into an office, technologically savvy enough to be able to perform work in a different way. And these are all questions that we haven't had to ask before.
Can you please comment on what is taxable income to the practice regarding the programs?
So I think you're referring to the PPP program, and I do not have enough specificity around that. So sorry, I would refer you back to either your accountant or to the lender, again, assuming this is related to PPP. Your lender may be able to help you with that as well as your accountant. I'm also not an accountant, sorry. So not a clinician, not a lawyer, not an accountant.
Thank you. How do you recommend dealing with very educated and informed staff members? They are very vocal about all these COVID programs because they can get info so easily online about what is available, and for some reason they believe it is their right to want to know what we are doing, what programs we are using, etc. Transparency seems to be the catchphrase. It is a fine line to walk.
You're absolutely right. I think it's important to tell your staff and employees that you're investigating all all options available to the practice. But at the end of the day, the company has to make decisions that are best for itself. So that may mean that you don't participate with certain programs because while you could receive the cash, you may not want to receive the cash. One good example that is a CMS advanced payment program. So CMS will advance you 25% of last year's receipts, effectively Q4's receipts. You'll get it within a week or so. You'll have 121 days of forbearance, and then they'll start chipping away at that balance for the next 210 days on all future claims. Well, that means that on day 121, every Medicare claim you submit, you're getting paid zero. You're just kicking the can down the road. For some practices, they're taking the money, keeping it in the bank, and then deciding whether or not they need it. For other practices, they need it. For other practices like mine, we're not taking it. And I don't think you have an obligation to your employees to defend decisions that your practice makes. But I do think you have an obligation to explain to staff that you're investigating everything and that you're applying for funds that are both applicable and that are financially sound for the company. And this is where I think shareholder meetings are really important, or board meetings are important, because it's important that board members in particular are wearing their company hat when they're making decisions, not their individual member hat. And so just like you're going to have individual staff that are questioning some decisions and wanting a lot of information, you're going to have some shareholders questioning some decisions that you make. So having a decision-making system that's nimble and that can move quickly is important. So we have a 3-member executive team as part of my company. I actually have a board meeting today with our extended board, and we're going to recommend adding a 4th member just from a balance perspective. But having that capability internally is going to be critical. But I don't think you need to, I think you just need to explain that you're investigating all sources and that you'll do what's in the best interest of the company to your employees.
What if the employees you kept during this crisis also applies for unemployment despite company paying them via loan?
Yeah, I don't know how that will work. I mean, eventually there'll be some reconciliation that the state will do. And so I imagine that the state will come back to those people now with 16 million plus people across the country of filing. I don't know how quickly they will do that or how easily they'll be able to do that. But I think some of this is outside of your control. If you're demonstrating that you're still paying the staff, then that's fine. I think that the other uncertain question, though, around this is if you've already furloughed staff and they've applied for unemployment and you get the PPP funds, and so then you have to bring back the furloughed staff back. How do you prevent the furloughed staff member who's collecting unemployment from double dipping during that 8-week period? If that was your question, I don't know that you can control that, but what I do think you can do to help protect your practice is communicate that for that period of time, they can't file their unemployment or they shouldn't double collect. You'll have to get guidance from your accountant on that. I don't know how that would work, but that would be the one concern that I have if you've already furloughed staff.
Thank you. And the next question I think you just covered. What happens if we call back the furloughed staff to satisfy the PPP, spend the money on salary and rent, then revenue doesn't improve? How can we promise not to have to furlough again?
I don't think you can promise that you won't have to furlough again. The PPP funds are limited in duration. And so the idea of the PPP funds was really in order to have some operating capital for businesses during this short period of time, expecting that we would then reopen, the light switch goes on, and everything goes back to normal. I think what we're starting to realize is that if that's not going to happen, then you may in fact end up just furloughing staff that you brought back It's not a perfect system, and that will happen to a subset of employees, not just in our industry, but every industry.
We did a layoff of 80% of employees. Are we able to hire back based on previous performances as well as needs?
So again, I would not tie any employment decisions to performance. I would tie it only to business need. You're going to walk a very fine line, and it's just one headache that you don't need. You've already got enough issues to deal with. Don't overcomplicate this. Base it on your practice need.
Thank you. And that was it for the questions that we have. So thank you, Brian, for your presentation, and thank you for taking the time to answer all of the questions that we did get. And once again, everyone, the presentation slides will be emailed to all participants, and the recorded version can be found on our COVID-19 resource page, as well as a quick survey will be coming your way as your feedback is important to us. And if you have any additional questions, please do not hesitate to reach out to the presenter directly. I hope you all have a great day, and thank you again for joining us.
Thanks, everyone. Take care.
Good evening, I'm Andrew Chang. Tonight, reopening brings relief and tension.
So you're not comfortable with going into a store yet?
Nope, and I love shopping, so that says a lot.
Alberta today, Ontario within days, but their approaches are different.
I'm Adrienne Arsenault, also tonight volunteering to test a vaccine.
People must be very clearly aware of what it is they're consenting to.
Why it's more important than ever.
There's not going to be penalties, and we're not going to punish people.
How folks taking an unearned pandemic benefit will have to pay it back.
And sidelined businesses that serve recreational sports.
Zoom lessons is good for the spirit and soul, but it doesn't really pay the rent.
Just waiting for the games to begin again. This is The National. Reopening the economy anywhere in Canada right now means taking on a tricky balancing act. On one hand, the need to relieve very real financial pain. On the other, that life or death risk of a spike in infections.
Today, major steps by 3 provinces trying to get it right. Quebec has scrapped its plan to reopen Montreal schools at all this academic year. With cases dropping somewhat, Ontario announced its restart will begin Tuesday and will be province-wide. Then there's Alberta. Its reopening began today, but infections there are shaping a different approach. All across that province, retail stores, daycares, and medical services are reopening. So are restaurants and hair salons, except in Calgary and Brooks, where case counts are still too high. As Carolyn Dunn shows us, there's a plan, but it's not sitting well with everyone.
Before Jen Oborowski can get her highlights, her masked hairstylist must take her temperature.
I'm really happy to have some normalcy. And of course, I mean, the roots need to be touched up.
Some normalcy, but not totally normal. Farmers markets are coming back, but with caution, and sidewalk chalk reminders to social distance. In restaurants, customers will be sitting further apart. Baristas and servers look like healthcare workers, while actual healthcare workers like dentists are employing full infection control.
So this is what a doctor would look like before. Nowadays, when you see him for a procedure like a filling, we have a full hazmat type suit that's a full body cover.
Business owners are taking a lot of extra steps to open their doors for phase 1. But not everyone is getting the chance, like some in Calgary and Brooks, Alberta, where infection rates are highest and there continues to be community spread.
We have to reschedule you.
So Rico El Sagir had to tell 2 weeks worth of booked clients his Calgary barbershop is not allowed to reopen.
A lot of them are not happy, with the decision because it's only Calgary. So people can go to many small towns around us.
Health authorities are asking people from Calgary and Brooks to avoid that temptation, risking further COVID spread. This Calgary Garden Centre could open its doors today, but it's sticking with online ordering and curbside pickup instead.
Just to be like leaders in the community and say, we're okay and we can do it this way.
And that's just fine for most of his customers.
So you're not comfortable with going into a store yet?
Nope. And I love shopping, so that says a lot.
In the end, reopening will happen only when customers feel safe. Carolyn Dunn, CBC News, Calgary.
Now, Ontario announced today it will start phase 1 of its restart on Tuesday. Jacqueline Hansen now with who will be allowed to open and who won't.
You're probably looking at about 150, or 200 guys.
Starting Tuesday, non-essential construction workers can pick up their tools again, along with extra protective gear.
I can see everyone wearing a mask. People are going to be wearing gloves more than ever.
Retailers with street access will be allowed to reopen, and some healthcare services, including post-operative rehab.
We've added in many policies and procedures. There's been a lot of sleepless nights developing these procedures.
Marinas, private campgrounds, and golf courses get a head start on Saturday. But just because businesses can open doesn't mean that they will.
Businesses should open only if they are ready.
Ontario's chief medical officer is watching the case count closely and says even this first phase of reopening isn't set in stone.
That's assuming things continue on the way they are over the weekend. Nothing all of a sudden urgently happens.
The owner of this shoe store hopes the province's guidelines for physical distancing and limits on the number of people in a store make reopening straightforward.
I think that it's going to help me with my own sort of nervousness and anxiety just in terms of adhering to the rules of the province.
This is our patio.
But many businesses are still waiting for the green light to reopen, like restaurants and bars.
We would have a table here, a table here, a table there, and a table just over here.
The owner of this brewery hoped his outdoor patio would have made the cut.
There are two parts of me. There's one part that wants to reopen tomorrow or yesterday. And then there's another part of me that understands that, this is a pandemic.
Officials wouldn't say what would be next in line to reopen. The focus for now is just getting through phase 1 safely. Jacqueline Hansen, CBC News, Toronto.
Now, any other year, lots of Canadians would be racing to get out of their cities right now ahead of the long weekend. But the pandemic has sparked fear in the communities we so often travel to. Fear of what happens if people all show up and what happens if they don't. Here's Ellen Morrow.
In northern Saskatchewan, a checkpoint near Green Lake.
Where are you coming from?
Many visitors own summer homes here, but there